to look at 3 different scenarios about declines and disruptions. And so I'm just going to quickly run through that now. So you can see an example here. So this is the tool, everything in yellow, you need to enter data. So we pulled in the trend of the CPR that's already preloaded into FAM plan. And we've pulled in the method mix as well. And we can see in this country, about half of women are using injectables, and about 40% of women are already using long-acting permanent methods. And so we have sort of half of women who are very at risk for COVID disruptions, but then another significant share of women who have fairly little risk because they can continue to use those long-acting methods. So then within the tool, you'll find this table. We have pre-specified some values for these 3 different scenarios of sort of low, medium, and high disruption, but you can change these if you'd like. And so for each of these scenarios, the first column is how much decline we expect to see in use of that method because of COVID. And then the second column, and this was added at the request of some UNFPA colleagues who were working on some scenarios like this, is that you could also specify the potential for some of these women to switch to using a traditional method, so that while the modern prevalence rate might decline, that you might see some buffering of that in the overall use of contraception. And so right now we've just assumed that 10% of all of the women who kind of discontinue or are unable to continue would then shift to a traditional method. And so what you can see here, if we just take the top line for condoms, so in our first scenario, we would assume a 10% decline, in our middle scenario, a 20% decline, and in our high scenario, a 30% decline. All right. And what the tool will do is then put out an output table for each of these different scenarios, showing you the drop, and we have the impacts of COVID sort of happening in both 2020 and 2021. And the impacts will be both on the CPR as well as the method mix. And so if you put these values back into Spectrum, then you can run all of the usual results that you can look at within the FAM plan model. And then the tool itself will also then show you the declines in CPR and MCPR that are estimated. And so we can see that in our very kind of severe scenario, that there is quite a large dip in the CPR going from 62% in 2019 all the way down to about 40%. That is a quick overview of the tool. And then I just wanted to share a couple of additional resources. I've put links in here so that when we share the slides, you can find these easily. So I mentioned before this micro model, which is less focused on the impact and more focused on exploring mitigation strategies. So what if you, and women who were unable to come for their injectable were instead offered an ability to get, say, contraceptive pills in a more socially distanced manner or things like that. And then I've put links, in addition to the work that UNFPA did on the transformative results, to some other papers and commentaries that have been exploring the impact of COVID in family planning. So that is all from me.
Thank you, Mitchell, giving that overview. Maybe now I invite Victoria from Johns Hopkins University to give us how we can use Impact40 in estimating the impact of COVID-19 on achieving preventable maternal death. Victoria, what you?
Yes. Hi, good afternoon, good day. I'm going to go ahead and share my screen. And I think most of you are familiar with the Live Safe tool. And so I'm going to walk through, provide some explanation, but feel free, if there are any clarification questions, feel free to type them in the chat. So the framework for the estimating the preventable maternal deaths is based upon the List Online platform. And so when you go to the main website, once you click begin, it'll take you to a dashboard. And I was trying to be which will show you the transformative results. When you're selecting preventable maternal, it'll highlight that the impact tool is going to be using the live save tool. So once you, see, I populated all these hoping that I would save a couple seconds. Once you select that, it'll bring you to a dashboard that just asks you to select your country of interest. And so currently, I will go ahead and explain where these data sources, what the data sources are, but I'm gonna select Uganda. As I know, Uganda has already had has been proactive in taking measures to address COVID. And you all are probably familiar, the idea for ending preventable maternal deaths, the understanding is that although the impact directly due to the virus among pregnant women is sort of unclear, and we're not really sure whether the health impacts from being infected by the virus itself are prominent. What has been documented and is increasingly understood, as Michelle mentioned, is that a reduction in care seeking and a reduction in utilization is what we believe will lead to sort of dire consequences if what we're calling sort of the indirect effects of the pandemic would lead to consequences for maternal and child health. So once we select the country, the dashboard is populated with what we have collated as default data sources. And so I say that because for us who are developing and maintaining the software, the idea is that we're trying to maintain coverage changes across countries and across time. So some of these interventions, if you have better insight at the country level and their inputs and you know more about whether or not there is current coverage of some of these interventions like calcium supplementation, micronutrient supplementation, et cetera, feel free to enter those. Those values can just be directly entered. But for us, our challenge is that, again, collating all of these data sources, there may not be a universal data source available for us to input for all countries. So when you're looking, the first thing to do is to examine what are the interventions which are listed and the baseline coverage, which is listed as a 2020 value. So each one of these interventions is interventions that are related to either maternal health or maternal mortality. And so I'll touch upon that later in our discussion. So the idea is that if I was to look and say, okay, you know, I review the data that have been populated that would say, this is what baseline coverage is, perhaps I'm going to assume that I'm going to look at these, the suite here of 4 interventions that delivered during antenatal care, and say I'm just going to roughly assume, for the sake of our discussion, that coverage is roughly 10%. I think 10% of the women who would be needing any of these services are currently getting them. And one of the challenges is that, again, you could estimate that based upon what current coverage is, say it's a 10% drop, or you could say, I think only 25% of the women are getting these services. So for the sake of simplicity, I've just entered 10%. So all of these values for these 4 interventions that I'm looking at for my analysis, I'm assuming are just going to drop to 10%. Our goal is that ideally, I think by the end of 2030, which seems like far away, but it is actually only 10 years, our goal is to reach universal coverage so that 90% of those women would be receiving care at the time that they would need them. So what I'm going to do is just interpolate. And so what that means is that I've just created a linear trend. So I'm going to go over that one more time. So these are the baseline values. I'm assuming that based upon what I'm seeing in my country, that may be based upon HMIS data or other sources or other surveys, pulse surveys, or different data collection strategies, that it's dropping to 10%. And then from there, I'm going to continue to increase to achieve the target coverage of 90%, which is my goal for 2030. So when I click view results, the software will communicate with the server to estimate based upon the calculations that list online we have for related to the effectiveness of those interventions, how effective they are, what the effective fractions are, et cetera. So when you scroll down, you're going to see these interventions listed, the ones that I've directly changed, because anything, for example, where coverage has not changed. So for example, manual removal of placenta, I haven't touched that. The coverage is baseline coverage remains constant. That doesn't show up in the results table. And so the results table are going to highlight those that I've manipulated or adjusted. And this negative, for our purposes, implies that because there is a coverage drop, typically lives saved works, the model works in such a way that if I scale up coverage, there will be a reduction in the number of deaths. And so unfortunately, what we're considering or what we're fearing is that with the pandemic, when we have a decline in services, we're going to see an uptick in the number of deaths. So this is where I say a negative life saved, we're going to, that would be reported, or that would be interpreted as an increase in mortality. And so we'll see that by those three interventions dropping in coverage, I'm going to see a total of about almost, close to 200 additional maternal deaths in Uganda. And then over that time, as I rebound or as I recover, 2022, there are no lives saved, nor there are no additional deaths because we go back to the baseline. And then there I've started to increase coverage to reach the target by 2030. And by each year, you'll see a steady contribution in the number of lives saved. The last thing I just wanted to highlight was just the Live Save tool is based upon, as I mentioned, intervention coverage going up, and therefore mortality or adverse health outcomes, morbidity would go down. One thing I did want to highlight is that the interventions that we have selected and listed for UNFPA, UNFPA is listed under the Impact40 tool, not all of those directly impact maternal mortality. So I say that because as you're changing some of those rows, you're like, that's weird. It doesn't show up in the bottom under results. The reason is because the interventions were selected, which are based upon sort of maternal health or maternal mortality. So for example, if I highlight something like diabetes case management has an impact to influence our rates of stillbirth. And so as much as I understand that managing screening and diagnosis and managing diabetes among pregnant women is an important antenatal care intervention, it won't directly have an impact to change the number of maternal deaths that I would see in the model. So that was the last thing I wanted to highlight, and I'll put the link for the visualizer in the chat. But the visualizer just allows you to kind of look at the pathways that are there to understand there are certain interventions like syphilis detection and treatment that are going to impact two causes of death. They're going to impact stillbirths and they're going to impact neonates, but they have no impact on maternal mortality. Whereas TT, something like TT that may be preserved with an EPI platform, or folks working in immunization, that is going to have a benefit to reduce neonatal mortality as well as maternal mortality. So that's sort of the end. I just wanted to highlight that the reason that you may see sort of a limited subset within the bottom results is just because some of them in the model have benefits for other subgroups in your population. So with that, I'll wait for any questions, but I look forward to hearing from colleagues. Thank you.
Thank you, Victoria. And colleagues, now we need to discuss about gender-based violence, how to estimate the, how to estimate the impact of COVID-19 on the gender-based violence. So we have John from Avenir. John, over to you.
Hi, this is John Stover. Thanks very much. I'm going to try to share my screen here and show you how this works. So for when you go to the Impact40 tool, and we're going to select gender-based violence. Oh, sorry. And estimate the impact. Now, the steps that I'm going to show you are all included in a little step-by-step instruction guide that will be on the website shortly, as Nadia showed you. So I'm just going to illustrate them for you so we get the idea of how to do that. So when you start, you're going to come into the GBV impact model, and you're going to select your country. So I'll just pick a country from this list. Let's try Bangladesh. And what it's going to do then is to fill up the model with demographic information and also information that we have about the current prevalence of intimate partner violence. And then you will also see the list of interventions for which we have found some evidence of impact in reducing intimate partner violence. We don't, unfortunately, have a database of what the current coverage of these interventions is by country. That's something that we've not been able to compile. There's not enough information out there. If you have information, however, you can fill this in. You can change these baseline numbers to whatever coverage you have if those programs exist today. Then what you want to do is to set a target. So you could go out to some year. I'm going to go to 2030, and I'm just going to, for purpose of illustration, set a target of 80% coverage. So suppose we scaled up all of these interventions to 80% coverage. And then we want to put in a scale up. So as Victoria showed, you can highlight all the interventions in all the years, and then right click with your mouse and click interpolate. And it will fill in the intervening years with linear interpolation. So now I have my base year percentage of intimate partner violence, and I have a scale up pattern for each of these interventions which have some proven effectiveness. So now I just need to click view results, and the model will do the calculations and show us over time changes in the percent experiencing intimate partner violence. You can see it's going from 22 down to 14 over these 10 years. And we can also see the number experiencing violence, the number of cases averted, and the cumulative cases averted. So now if I want to compare this with a COVID scenario, one thing I can do is highlight these numbers. I'm just going to outline all those numbers. And if I right click with the mouse and click copy, I can just paste these results into Excel. So now I've saved them, and I can use them to compare them with another scenario that I might create. So how do I create a COVID scenario? So there's two considerations that we've looked at. So one of them, the main one we felt, is that as a result of the disruptions due to COVID, plans to scale up these GBV prevention interventions will be delayed. It will be harder to get the funding, harder to get the people, harder to get things started. So maybe the delay would be quite short, but maybe it would be longer, so as long as a year or two until things get back to somewhat normal. So what I might do is to say, let's assume that there will be a 2-year delay in getting started with scale up. So I'm not going to have any scale up at all in 2021, and it's just going to get started perhaps in 2022. So I'm going to make that change in 2021, and then I'm going to reinterpolate. In this case, notice that I'm making the assumption that we're still going to get to full coverage by 2030. That might not be the case. We might want to have a lower coverage in 2030. Whatever assumptions I make that change, and then I just click Update Results. And then the results will recalculate, and I can see my new results. So if I copy these new results back to the Excel file, copy. So I can look at my cumulative cases averted, for example. Here in my original case, I assumed 21 million cases averted. Now with the 2-year delay, that reduces down to 19. We still get to the same point in terms of percent experiencing intimate partner violence, but we take a different path to get there so that the cumulative cases averted will be less. So with this approach, you could map out any type of scenario describing how you think that COVID might affect your plans to get your prevention activities scaled up quickly, and see how that would affect overall. And then those numbers could be used for advocacy purposes to try to convince people that it's important to try to quickly get back to trying to achieve that plan. One other thing I wanted to mention is that the other impact of COVID that we might be seeing is an increase in reported cases of intimate partner violence today because of the lockdown. So we have evidence from some violence prevention sites, helplines that people call into, that in some places they've seen increases of 10, 20, or even 50% in the number of calls. Other places, however, have seen a reduction in volume of calls, which may or may not mean a reduction in actual violence, but maybe just a reduction in reporting for various reasons. So we don't right now have that built into the model because we just don't have enough information to understand what kind of patterns we might be seeing prevalently. In your country, if you have information, perhaps from hotlines or whatever, about the increased volume of calls, then you might want to adjust this figure for 2020. In the global analysis, we illustrated this with a 20% increase just in 2020. I know it got a lot of interest from people. We don't really have very good backing for that 20%. It was just an illustration. But in your countries, you may have some data from your call-in centers that could help you speculate about what that increase in violence actually is, and you should include that in any assessment you're making of the impact of COVID on GBV. Thank you very much.
Thank you, John. And now we are gonna move to the female genital mutilation, the impact of, estimate the impact of COVID-19 on achieving ending female genital mutilation. So we have Rachel from Avenir. Rachel, over to you.
Hi, everybody. Thank you for taking the time to join us today to have this discussion. I'm going to share my screen and talk a little bit about how we have transitioned some work that was done to estimate the possibility of achieving reductions in FGM cases using prevention programming to think about what the implications of COVID-19 might be for these kinds of programs. I'm sorry? Okay, could everybody mute, please? So we do know that some of the most important programs for prevention of FGM are social mobilization programs and community empowerment programs that by design bring communities together, bring people together, and are not going to be possible during COVID-19, social distancing, and other restrictions. As a result, we have started to think about what the implications might be in terms of scaled up FGM prevention. So we looked originally, for those of you who've explored the Impact40 site, I'm sure you're aware that we looked at an original analysis that looked at the possibilities of achievement for programs that scaled up from 2020 to 2030. So for the alternative scenario where we are now incorporating the impact of COVID-19, similar to what John described for gender-based violence, we looked at a 2-year delay. So this is a screen that just shows the different primary parameters and how they're different in terms of the counterfactual to which we're comparing each of the scale-up plans, the primary scale-up scenario in which we looked at programs that scaled up starting in 2020, and then our COVID analysis assumption. So for all of these, we look at a base year of 2020, and then we assume that historic trends continue to be underway. For the first year of intervention scale-up, though, in our primary scenario, we looked at everything starting to ramp up, additional programming in 2020, but in the COVID analysis, we start in 2022. Same expected intervention effect on positive attitudes towards FGM in both scale-up scenarios. But the most important factor alongside the delayed scale up is what can be achieved by 2030. So we assumed a similar increment each year, even though we start a couple years later. And as a result, by 2030, we've only managed to achieve 80% coverage using direct and indirect methods, whereas in the primary ambitious scenario, we looked at achieving 100% coverage through direct and indirect prevention programs. So when we look at the implications of these findings, you can see this graph on my screen. The the counterfactual, or the scenario in which there's no scale up of prevention programs, there's only a decrease in FGM due to historic trends. You can see that it's falling from about 4 million cases each year down to about 3.5. And then the middle line is the COVID scenario, in which it's you're still preventing an additional number of cases, but it's much fewer than in the no COVID scenario. So we have, what I'm presenting here is a group of countries. It's about 31 countries where we had enough data to run these analyses. I've grouped them together for the purposes of this presentation, but we've prepared them in an Excel file that you can find on the website that was presented earlier. And so you'll see each of the different countries with a counterfactual, a 2020 start, and a 2022 start, and you can pull out the individual numbers for your given country. If you are interested in exploring alternative scenarios, please be in touch and we can help you to develop the spreadsheets to address that. For costing, it's relatively straightforward. For the impact, we need to do a bit more of a complicated analysis using the background data. So we hope this information is useful for groups as they think through what impact COVID-19 might have on different programs, and we look forward to any feedback. Thank you.
Thank you, Rachel, for giving that overview. So maybe colleagues, now we have the last transformative results, which is ending child marriage. So as you know, we are doing this presentation in collaboration with our partners, Johns Hopkins University, Avanea Health, and Victoria University. So we have our presenters from Victoria University, Bruce and John. Over to you.
It's Bruce Rasmussen. Good evening, good morning, wherever you should be. Very much evening where I am. When we last met in this webinar series, we talked about creating your own scenarios through customizing costs and effectiveness of the interventions to reduce child marriage by a target date of 2030. And we showed you a bit about how to do that. And this time we're talking more about customizing the model to take account of COVID. And in our assumptions about the effect of COVID on child marriage, they were two factors. One was, as John mentioned, I think in female gender violence, as gender-based violence, the one effect is to delay the introduction of these interventions, perhaps by a year, maybe 2 years. And our model which John, my colleague, John Simons, will introduce shortly, shows you how to do that. The second effect is a slightly more complex one, and that is that, as you well know, child marriage is associated with poverty. And so increasing poverty increases child marriage. And one of the things that we did in our estimations is to introduce a factor of the increase in child marriage as a result of the economic downturn, which is in progress right now. And when we did that, when we did those estimates, it was early days, it was April. And we took some of the best available data at that time for the size of the economic downturn, which was projected for 2020 into 2021. And that was a midpoint of around a decline in GDP per capita of about 10%. Now, that implied an increase in poverty, number of people in poverty, of about 250 million people. Since then, the World Bank has come out with its global economic prospects and has done some work on the implications for poverty of those projections. And perhaps fortunately for us, have the mid-range of outcomes is around about 250 million, the same number as we used. But what is very clear, two things. One is that's 250 million without any income distribution effects. And as you well know, we all well know, COVID targets the poor. So we expect that there'll be an increase beyond that 250, but that's not in these numbers yet, but it's something that we're encouraging you certainly to look at and to introduce. The second effect is that the economic effect is very different across countries. And we've seen that in some extraordinarily different countries. So for the United States, for instance, India and Brazil. And it's expected that per capita incomes in India will decline by more than 10%, similarly in Brazil. Whereas in some countries in sub-Saharan Africa, where we thought that there would be a significant effect of COVID, that hasn't actually occurred. So this model allows you to introduce different increases in the child marriage rate as a result of COVID, and you can see some of the effect of this increase in poverty. I'm going to hand over to John Simons, and he'll actually take you through a version of the model. Thank you.
Thanks, Bruce. Just check if I'm able to share the screen, my screen at the moment. Okay, so hopefully the Excel spreadsheets come up.
Yes.
This is available through the Impact40, will be available next week through the Impact40 website. And as per the other sort of modelling approaches, this one is able to take in various factors which you can change, which are in the green cells. So anywhere from the discount rate, the target rate by 2030, which we set at 5%, as well as the various interventions that the cost per the interventions you can change, but they are automatically update to certain figures we've established for each country, and the effectiveness as well. So the way modelling works, the way you're able to do it is you select a particular either state of India or a country and the region within that country or state, either the total area, or the urban or the rural area. Once you've selected that area and you're happy with the discount rate and your target rate, you can then click on the Solve Optimal Solutions, and that will, because we're pressed for time, I won't do it because it takes several minutes because it's an optimization model. It will then select the results, the interventions which will achieve that target rate by 2030, and automatically take you to these results page showing all the costs per year and the amount of child marriages averted per intervention per year, and that as that trends through time, the graph of it. What we've done with taking COVID into consideration, as Bruce mentioned, due to the increase in poverty, which we calculated in the early days in April, that may lead to about a 1.4% increase in baseline of child marriages. That can be changed to any figure you choose. So you could change that simply to 5%, and the model will automatically adjust. You can also change the start year, and it's expected that the interventions will be delayed for the reasons mentioned in the other presentations, for lack of finances or for whatever reason. And you can choose whichever start year is most suitable, either 2021, and then you can reach the full implementation year, whichever one you think is most appropriate for your situation. So when you've selected all those, I'll take it back to the 1.4 that I had before. I won't do it now because that actually takes several minutes for the program to run. I've previously run it just to show you a set of results for Andhra Pradesh in the rural area. So what this produces is the costs, the total number of child marriages averted up to 2030, the cost for each intervention per year, and also the number of child marriages averted per intervention, and gives you the NPV, the net present value cost, for the discount rate that has been set in the previous tab. So that comes up there with also particular cost categories shown there as well. I know it's very quickly run through it. I know we just don't have much time, but that's the basic way the model works, and it is quite customizable to each particular country, where you can change the discount rate, the effect of COVID, your target rate, and also your start year to take those things into consideration. Is there anything else you wanted to add, Bruce? You're on mute, Bruce.
Thank you, Bruce and John. I think that was very helpful, and thanks for doing that, overview and that demonstration. So, colleagues, that's the end of all our presentation, the technical presentation on how to use Impact40 in estimating the impact of COVID-19 on achieving the transformative results. So my colleague Howard will facilitate the question and answer session. But before that, I want you to request you to post your questions. I know you're already doing in the chat box. So we will be able to just answer real time or take some of these questions at the end. So, but we need to have like a very quick discussion with our colleagues in Asia and the Pacific office, because as you know, colleagues, some of the countries are already being, estimating those impact. COVID-19 impact on achieving transformative results, including Asia and the Pacific. So I just want to invite David, our colleague in Asia and the Pacific office, to give us a very quick overview about your work, the work you have already done, the countries in the Asia and the Pacific in this area. Then we can start the question and answer. David, over to you.
Thank you, Taranga. I won't really present anything. I just want to say thank you to you and the team for the presentation and for actually the valuable, I think, improvement that you made to the models. I also want to thank Michelle and Rachel, because they really helped us in developing the country-specific impact analysis that we done here in APRO. APRO has supported 20+ countries already in developing analysis of the impact of COVID on family planning and maternal health, using basically the similar methodology that you presented. But at the time, Impact40 wasn't available, therefore we used the original spectrum. And I'm happy that now I think we will be able to do more or less the same using the Impact40. So this is very encouraging. I think I only have a question for Victoria, if allow me. I want to know the reason why in the Impact40 is not possible to change the baseline for maternal mortality ratio, and also it will be useful, in my opinion, to see the impact of the changing coverage and intervention on MMR also as an additional result, in addition to maternal deaths, which are included now. Finally, I think we also welcome the flexibility that you added to the GBV models, because I think we can now attempt to run some projection for GBV as well. I foresee maybe possibly problems in terms of availability of data. And I guess that would be the most, and the interpretation of data, that would be the most challenging aspect of using this tool. That's all. Thanks again, guys, for all the good work you've done. And I think this will be very useful for all the other countries going forward. Over.
Thank you, David. And we really want to hear from you and learn of some of your work. And that would really help us to improve the Impact40, the UNFPA tool for estimating the cost and impact and cost of achieving the transformative results. So that's, colleagues, that's the end of all the presentations. So now I will hand over to Howard, my colleague, to facilitate the question and answer session. Howard, over to you.
Thank you very much. And first, thank you so much for the great presenters. I really appreciate it. And we have a little bit amount of time. We've got some great questions in the chat box. I'm gonna start by, since Davide tossed that question over to Victoria, we'll start with that first one, which is regarding the MMR. But I want to tell you, we have some very good news. So Victoria, do you want to answer that one, or would you like to?
No, I was just going to say, Howard is amazing because he reads minds. And so he, one of the changes that we're actually, my understanding is going to go live shortly as soon as power returns in Connecticut is the one that you had mentioned, which is showing the MMR up at the top. And so given the uncertainty related to country-specific estimates of MMR, that will be displayed. And I'll turn it over to Howard and or Nadia to follow up about sort of any additional, but they sort of anticipated that would be a request. And so kudos to the team on that side. Howard, over to you.
So great. So the answer is we have good news. That's actually a feature. It's already in the beta version. We'll be moving that over to the official one, hopefully in the next week or so, assuming that people get their power back. I want to start with a question that's really quite overarching, and I'm going to start by asking Michelle to answer it, which is really describing the rationale behind the scenarios of the disruption. What was the basis for it, and are there perhaps data-driven ways that countries can go about modeling these disruptions? So let's start with Michelle, but it's not a family planning specific question. So if afterwards other researchers want to comment, that would be great.
Great. And then I'm gonna share my screen. So this is a slide, and we can send around a reference for this from some work that myself and Rachel and Nadia were involved in for looking at the impact of COVID in Burkina Faso. And for this, we put together this little framework. What you'll see is these values don't exactly match to the assumptions that we have in the family planning tool, but are quite well aligned. And so I just wanted to share this as maybe something to think about what these impacts might look like. What I will say is, you know, there are many uncertainties, right? We have uncertainties about how long, you know, COVID will be with us. We have uncertainties about how quickly things will change in countries, and every country is reacting differently, implementing different policies. And so I think, you know, the reality is we have no way to know what the true disruptions are going to be. And so I think the best that we can do is use the information that we have from other experiences. So this draws very heavily on work that was sort of done looking back at the impact that Ebola had on different services. And then again, drawing from what people are seeing in their countries, what they're hearing, what they can see within their HMIS data, where countries have that. Though I saw in the chat, someone made a very good point that, you know, in some places there might also be disruptions, might also mean people aren't reporting as well into those systems. And so we want to be careful to tease out what is, you know, a change in service utilization and what is a change because clinics are not able to get their reports in. So that data is more incomplete. But what we thought about for this work was that, you know, and this again was not just for family planning, this was across a whole wide range of health areas. So I think this could be used for everything that we talked about. But there seem to be sort of two different dimensions that are at play. So one is the level of touch, sort of how much interaction there is with healthcare providers, and that the more touch, sort of the more disruption, but that then is sort of tabbed with an idea of time sensitivity, right? And so things that can be delayed without significant health impact or consequences, people are probably more likely to delay. Whereas things that really can't be, people are more likely to still find a way to try to get to that service, even if there is disruption and even if there is that high level of touch. And we actually saw that, you know, in Ebola, right? So we saw that generally there was big drops in inpatient care services, but those drops were not as big for things like childbirth, right? Because there are things that just, you know, could not be put off, and so people made more efforts or were better able to get to those services. And so based on this, again, these are sort of our best guess using the data that we have, the experiences that we have, to say, you know, we don't know exactly what will happen, but we expect some services to be more disrupted than others, and we expect, you know, some sort of range on this. And you can see here the range is quite big. This range comes from the ranges within this Ebola study that's referenced there. So even, you know, within Ebola, as they looked at different subnational areas, you know, the level of disruption varied greatly. So I think all of this is just to say we have a lot of uncertainty. So I think in this work we want to always be presenting ranges so that we're not saying we are predicting this is exactly the future, but we are saying that, you know, it could be somewhere between A and B.
So thank you very much for that. It's very much appreciated. Our colleague Jyoti actually pointed out that in ISARO, they actually have real world disruption data for 19 of the 23 countries. And that's a key take home message. When you have real world data, please use it. Also, as Michelle described, use multiple scenarios, because even if you have one measurement, there's still uncertainty in the current measurement as well as in the projections themselves. The comments are quite rich, and I want folks to know that we'll capture that information. We will, of course, be responding to them. We unfortunately are running a little low on time, and so I want to just leave you with a couple of quick thoughts before passing it back to Thoranga to wrap up. The first one is, the reality is modeling itself is a dynamic process. We learn, we change, we adjust as new information and new techniques become available. COVID modeling is no different. The COVID forecasts are getting more accurate as we understand transmission drivers, mitigation strategies. Our COVID impact modeling is getting more accurate as we move from these theoretical assumptions to using actual service disruption data. Let's continue to learn. I think what you've seen from this webinar is that we are improving the tool based on your feedback, and we're going to continue to do that. But we're an organization, so we listen to each other. Send us your suggestions, send us your recommendations so that we can help make this tool better to support our countries and the populations in need. If you have lessons learned, like the great work that's going on in the regions, let's make sure we're sharing that and communicating. And lastly, if you have technical questions, you need support, by all means, send emails to myself, Thoranga, and we will, of course, make sure you get the support you need, whether it's through Avenir, Victoria University, Johns Hopkins, or other areas. With that, I want to pass it back to my colleague, Thoranga, for the last word.
Thank you so much, Howard. And so colleagues, thank you for joining this webinar. I think it was very rich, webinar, and we had a lot of things to absorb. And so maybe I just give you a couple of next steps. So I see the need of having, follow-up webinars, discussions around this. So we will be seriously thinking about it, and then, discuss with some of the colleagues and see how we can do more discussions around this topic and give you more guidance on this area. So the first announcement is, as you know, we have not updated the Impact40 yet with these sheets or these options because of some of the difficulties we faced in the past couple of weeks here. So, but we will be doing it very soon, as Nadia mentioned, and we will inform you when they are ready. So then you are ready to use them immediately. And the second point, we know that we want to encourage you to use Impact40, as Howard said. This is the UNFPA tool, and we developed together with you. And we see a lot of interest from other donors also to invest this area. And we are thinking about releasing Impact40 to public end of the year. Then all our partners can use it. So please use, and as Howard says, please provide your feedback to us to improve it. So as Howard said, we are always with you to help. I know, because you may have so many questions in this area. So feel free to write to us, or you can just go to Impact40 website and there's a help button. Just click it and submit your questions. So we are happy to, we means like UNFP and our partners jointly, we are happy to come back to you as early as possible. So those are some of the messages. So I just want to take this opportunity to thank all the presenters, our partners from Avenir Health, Johns Hopkins University, and Victoria University. So you are always with us in terms of estimating the impact and cost. As colleagues, as you know, we are in the process of accelerating our process to achievement of the transformative research. So this is the critical factor for the acceleration. So that's all from our side. Thank you again for colleagues joining. So we will be soon having another discussion. We are thinking about sharing the recording with you. Then you have more time peacefully absorb some of these discussions we had. So thank you again for joining, and thank you for all our colleagues helping us this webinar. Thank you.